So this is the second day of the fourth PTAC public meeting, and we are going to start right in with reviewing the proposal submitted by Avera Health, Intensive Care Management in Skilled Nursing Facility Alternative Payment Model. Grace Terrell is, like I said, Grace Terrell is the lead, Harold Miller, and Kavita Patel. I've worked with her for a long time, but I was just making sure she was on top of her game this morning. So what we're going to do as we start is we're going to go around the room and introduce ourselves and also declare any conflicts of interest potentially or impartiality. And I'll start with myself, Jeff Bailett, Executive Vice President of Blue Shield of California. I have nothing to disclose. Bob?
Yes, I'm Bob Berenson. I'm an internist and a fellow at the Urban Institute, and I have nothing to disclose.
Kavita Patel, internist at Johns Hopkins and a fellow at the Brookings Institution, nothing to disclose.
Lynn Nichols, a health economist at George Mason University, and I have nothing to disclose.
Elizabeth Mitchell, President and CEO, Network for Regional Healthcare Improvement, nothing to disclose.
I'm Mary Ellen Stahlman, the ASPE staff lead for PTAC.
Ann Page, Designated Federal Officer for PTAC, which is a Federal Advisory Committee Act committee.
I'm Bruce Steinwald, a health economist here in Washington, D.C. Nothing to disclose.
Paul Casal, Executive Director of New York Quality Care, nothing to disclose.
I'm Harold Miller, the CEO of the Center for Healthcare Quality and Payment Reform, and I have no conflicts or disclosures.
I'm Grace Terrell at Wake Forest Baptist Health. I'm a general internist and the Chief Executive Officer of Envision Genomics, and I have nothing to disclose.
Tim Ferris, primary care internist at Mass General Hospital and the CEO of the Mass General Physicians Organization, nothing to disclose.
And I skipped Sarah.
I'm Sarah Solinich. I work in ASPE and I help support this preliminary review team.
And I said it yesterday, but I think it warrants repeating. The staff that supports our committee is phenomenal, starting with Mary Ellen, but Ann and Sarah and all the other folks who are behind the scenes helping this committee maximize our potential. So again, real heartfelt thanks to you, Sarah, Ann, and Mary Ellen and your team, and all the folks behind the scenes here who are making this happen. So we're greatly appreciative of that. I'm going to go ahead and turn it over to Grace Terrell. Grace.
Good morning, and it's my privilege to lead the PRT team that consists of myself, Dr. Kavita Patel, and Harold Miller, who reviewed this proposal for nursing home intensive management from Avera Health. I have nothing to disclose, but I do have something to say, which is I'm very excited to see those that are working with nursing home patients involved and being citizen patriots and coming up with things that's going to make our healthcare system better, particularly with this group of individuals that are so vulnerable and important in terms of the care that they receive in our system. I started my first job in high school, washing dishes in a nursing home. I've been the medical director of a nursing home. I've been on call for up to 10 nursing homes at a time. So I was feeling this one personally. I know Dr. Patel also has experience taking care of nursing home patients. So we, in particular, had a PRT that understood the importance of this. Mr. Miller also expressed us some of his own personal experience with family members in a nursing home. So thank you for doing this, and we're going to get into the details related to what the proposal ultimately said. I am not going to read it line by line, as was said yesterday. So the name of it is the Intensive Care Management in Skilled Nursing Facility Alternative Payment Model, which I will not say correctly any more than our chairman said Dr. Terrell correctly for the rest of the time, probably, as we tended to call it, the proposal from Avera Health, which is the name of the organization that did that. So to basically review again how these presentations are done. in what we do to get to the point of the public meeting. We have the PRT, which I introduced to you all, followed by an overview of the proposal, a summary of that. We're going to talk about the key issues, and then we're going to go through and how we thought about each of the Secretary's criteria. And after that, there will be a time for the committee to ask us questions for clarification. There will be the opportunity for you all to then come up and we will ask you questions. You'll have a chance to speak, and if there's anybody in the public that wants to also participate in this. So the role of the PRT is essentially to have members who will go into thorough detail of these reports to prepare the overall committee, commission to look at it. We, in our situation here, the 3 members had several meetings about it. We interviewed the submitters. We also had a series of questions that went back and forth, and we also got data that we asked for in order to basically look at some of the analytics and the numbers behind things. And after that, we had at least 3 meetings, I believe, after all of that, for which we put together our thoughts in the report. So this report is based on a healthcare innovation HICIA type of award round 2 demonstration project that Avera Health had been part of. The goals of the model were to reduce avoidable emergency room visits and hospitalizations and lower the cost of care for patients that are both in skilled nursing facilities and nursing facilities. There was a proposal that it be an alternative payment model and that the geriatric physician in practice would serve as the APM entity. And the services supported by the payments proposed would be geriatric care, geriatric-led care teams that would partner with Sniffs and other nursing facilities and supplement the facility's on-site services through telehealth. In addition to the geriatrician, the submitter suggested that there could be other members of the team that would include geriatrics-trained support individuals, including advanced practice providers, pharmacists, social workers, nurses, behavioral health. But there was a great degree of freedom within the proposals such that there could be choice made with respect to whom was needed on the team. The beneficiaries would continue to receive the type of care they typically would from the nursing facility, as well as a primary care physician. This would not supersede that, but would be a process in addition to that to improve the care. It would, the type of services that would be rendered would be monitoring through telehealth for the facility itself and the staff to have access to telehealth, and also for the development of care plans, evidence-based disease management, advanced care planning, and the other types of things that it's asserted currently are not necessarily done with the ability to have geriatricians involved at all nursing facilities due to the shortage nationwide of that. It would also provide a 24/7 access to geriatricians, which is something that, again, is not common in current nursing homes very frequently across the country. So the payment model, which was based, again, on the care model that had been flushed out in their HICIA award, was 2 different options. Common to both of them was a upfront initial payment for the member, as well as a per member per month fee. So in both option 1 and option 2, that was there. There was no beneficiary cost sharing. And when we asked in detail whether this would be shared with the facility in any way, the answer was it would be up to the to the geriatric-led team, the APM, if that was to be the case. There were 11 performance measures, of which the APM entity could also monitor an additional 13 measures, and failure to meet standards on 6 of these would result in discontinued participation. There were 2 options within the model. The first was essentially based on the per member per month, as well as the upfront initial fee, and where there would be changes based on performance in year 3 if they did not meet 4 of the measures. Option 2 was based on the ability to participate as a result of the macro legislation in an alternative payment model by also providing a payment model that would create some risk involved for the participants. So in this particular situation, there would be, they would be eligible for shared savings beginning in year 1, risk for shared loss beginning in year 3. The savings would have a limit to 10% of the target amount. The losses would be limited to the new admission and per beneficiary per member per month amounts. The actual Medicare Part A and Part B expenditures for all health care services rendered by the residents would be measured, as well as 30 days post-discharge, and then beginning in year 3, the savings loss would be adjusted based on performance measures, with savings reduced for failure to meet 4 standards and losses reduced if standards not met on at least 8, were met on 8. So this won't take a whole lot of time to explain, but our committee essentially looked at the 10 criteria, and after significant amount of discussion felt were unanimous that they met the criterion on all 10 of the Secretary's standards. There were key issues that we identified. One of them is there's already some models out there that are really looking at this population of people with, that are in skilled nursing facilities and others, but that there is significant opportunity to, for improvement, and there is not necessarily models out there that are tied specifically to the types of payment models that they are proposing here. The beneficiaries will receive 24/7 access to the geriatric-led care team through telehealth, and it seems like that will more than likely improve the quality and reduce the cost by avoiding emergency department visits and hospitalizations. So this sounds like something that will be very positive by basically, hopefully providing care that would otherwise have someone go to the emergency room or the hospital for evaluation. We support the concepts that are in both of the payment models. We do believe that there are some nuances within some of the details of their payment methodology, which we can go into, and I'm sure that we will talk about more as a commission here in a minute, that could improve it. And it was, one of the other concerns is it was designed to work with a population of at least 5,000 beneficiaries. And there was comments in their proposal and in the questions when we asked them that they thought that it could work for smaller numbers of beneficiaries, possibly in some more remote areas or rural communities. But much of that was not flushed out, and it would certainly be something that would have to be thought through in great detail by CMS. Our PRT felt that this, as we've had with other examples in the past, might have been a stronger proposal had there been simply a single model for payment, because it makes it a fair amount of complex, fairly more complex to actually think through both of them and provide feedback. It again is one of those proposals that we have where we have to think about the imperative many people feel about coming up with a risk or a shared savings model to qualify as an advanced alternative payment model, and whether that is influencing or not the way many of these payment models are being proposed. One thing was that the proposer said that the shared savings would allow for greater flexibility, but there was not much information provided as to how, by virtue of having the risk and the shared savings, it would allow for greater flexibility. That's something we may want to flesh out with them in more detail today. Neither payment option proposed a way to risk adjust with respect to emergency department visits, hospital admissions, or spending based on the specific type of patient characteristics. There are not necessarily a lot of good risk adjusters out there for nursing home populations, but because of the broad potential of this type of payment system, it seemed to the PRT that there might be an opportunity to think through how that could be done or should be done or whether it ought to be done. And then one other significant issue was that it ties, the model ties directly payments to quality health outcomes indicators of health cost management, which is good. But it was a bit asymmetric with respect to the risk involved for not meeting those standards. And in fact, you could potentially get payment even if the cost went up based on some aspects of the model. So I'm going to go through the 10 criteria. The first criteria is the scope. It's a high priority criteria. The PRT felt that it met the criteria that, as I had previously said, there are existing models out there, but this certainly expands the options that are out there for this population within potential payment model. It also provides an explicit opportunity for geriatricians to participate in a payment model, which has not been out there in anything proposed currently, although the committee did feel that this needed to be thought through as something that could be expanded to appropriately trained internists or family physicians who might also provide a lot of geriatric care. It was designed to assume that as I mentioned before, that it would serve a population of 5,000, but we do need to understand whether that would be feasible with smaller populations. And there was a lot of flexibility in the model. It's not real clear to the PRT how much of this depends on all of the units that are part of their model as opposed to part of them. So, for example, is telehealth an absolute necessity with this? Could the types of services be provided or the payment model be done in a different way? So these are some of the things that we felt needed to be explained in more detail. With respect to the cost and quality, we felt that the likelihood of 24/7 access to a geriatric-led care team would probably improve the quality and reduce the cost by avoidable ED visits and hospitalizations. There is data that we received from their work with the HHS Round 2 award that some of that data was happening in real time as we were interacting with them, that essentially shows that there is some positive return as a result of this. But we also saw that there are other areas of the country where there is a much higher cost of nursing home care, for which there may be even more potential than the particular region of the country where they're doing this type of work now, where the costs are already relatively low for nursing home facilities. So we thought that was positive. The model will hopefully incentivize the care teams to partner with facilities where they perceive the most opportunity based on patient characteristics. Since the one-time and per member per month payments are not risk adjusted, so we are concerned about the perennial issue of cherry picking if this isn't thought through from that context. And there needs to be a means for which we can make sure that appropriate hospital services are actually provided. So with respect to the payment methodology, which I described earlier, we support the fundamental concepts in both the upfront fee, the per member per month, as well as concepts of the shared savings and shared risk. We do believe that the two-sided risk option incentivizes appropriately to reduce avoidable emergency department visits and hospitalizations. There is, with the simpler payment design, less complexity, but also less financial risk, which may allow greater participation from those that do not have this level of infrastructure or sophistication. But that in and of itself may have some, also some concerns that there would not be as much savings as a result of that. The downside risk versus the upside shared savings is asymmetrical in the proposal, which we felt needed to be explored as to whether that actually creates the appropriate degree of incentives for the type of care that needs to be provided. And again, the lack of the ability to actually risk adjust for ED visits and hospitalization admissions may create some perverse incentives that need to be thought through with the model if it's put in place by CMS. The more details of the payment methodology, and we're going to spend more detail on this than some of the others because we really feel like the crux of this is in what's been proposed here. The performance measures would not impact payments in years 1 and 2. The 11 measures include emergency department and readmission measures for the SNF patients, but not for the non-skilled nursing facility patients. And the performance measures do not negatively impact payments unless the alternative payment model entity fails to meet the standards on at least 4 measures under the shared savings option. So therefore, as I was mentioning earlier, it could fail to meet the standards for emergency department visits and readmission measures for skilled nursing facilities and not have an adverse performance adjustment. And under the shared savings model, performance factors only into the shared savings and loss payments and does not affect the monthly payments. So these are some nuances we need to understand the impact of better. The simpler model option does not provide an increase in payments for good performance, which, given its lack of complexity, there may be some limitations, therefore, to the flexibility of the type of services that could be innovated as a result of that payment model. In terms of value over volume, we believe that it met those criteria. The services are not, the entity is not paid on a per service basis, but on a per patient basis. So from that point of view, it would not necessarily perversely incentivize excessive services. The entity is expected to risk stratify patients to help deliver the right amount of care, but one of the points that need to be made, and it's not their fault, but there is not a lot of good long-term data in terms of risk stratification on this population, so that may create some opportunity for CMS to actually work with this type of proposal to come up with ways where the risk adjustment could be improved. The model provides for patients who are in skilled nursing facilities and nursing facilities far more flexibility in how the facilities can respond to the problems of the residents as opposed to just sending them to the ED or where they get admitted to the hospital for things that could be managed there. As I mentioned earlier, there is some discussion about flexibility being part of the shared savings, but not a lot of details as to how that could be done. The ability to be evaluated is something that we think is also it met the criteria because we can measure the numbers of emergency department visits as well as the cost and the hospitalization. The proposed measures are also things that are currently in other reporting programs and can be evaluated. The ability to think through this with respect to severity adjustment, though, as we were just discussing, may be more complex as there are not currently risk methodologies that can do that. We do believe there is the opportunity for improved integration and care coordination in this model by virtue of having the access to geriatricians and team-based care that have, through telehealth, improved the access across large populations of nursing homes where that's not the case now. There is, it's very specific in the model that the primary care physician is still part of the team, is the one who's responsible for the patient, but there is not actually explicit ways in the proposal how that integration and care coordination with the primary care would be guaranteed. So although there is a need to understand that this is providing the opportunity for integration and care coordination, it's not actually explicit about how that would be done or whether it absolutely must be done with what was proposed. The model provides improved patient choice by offering patients something besides going to the ED or hospital for care that would otherwise could be provided with the help of geriatric expertise and team-based care at the nursing facilities itself. There is also the option in the proposal for the patients to opt out of this if they didn't want to participate. We did ask and cogitate a bit on what that would mean with respect to a nursing home facility if they are involved with a with this proposal, if they have patients who are not willing to be in this, if that would actually disrupt process. We didn't believe that was an overall negative with respect to patient choice, but it may actually at the process level increase complexity at the level of delivering these services if it's not across the board at a nursing facility. We believe that it meets the criteria of improving patient safety by virtue that there will now be 24/7 access to geriatric consultation care and expertise with the team in facilities that did not have that. There is always, in any payment model, the potential incentive of patients who ought to appropriately be admitted to the hospital, not going to the hospital by virtue of the risk portion of the model here. We do not believe that that was a strong enough concern that we did not think it meets criteria, but it ought to be thought through in terms whether it's risk adjustment or audit or otherwise to make sure that patients who ought to stay at the facility, that those who ought to go to the hospital get there without there being incentives for them not to do that if it's appropriate to do so. And finally, with health information technology, telehealth in it of itself is integral to their proposal, and therefore we believe that it meets the criteria on this hands down. One of the concerns we had is because nursing facilities were excluded from the original high-tech incentives for meaningful use in other parts of federal legislation that really pushed many other types of healthcare facilities into having electronic health records, because part of their methodology is based on having access to electronic health records of patients, and not all nursing facilities have that right now in the U.S. They tend to be a little bit lagging behind the rest of the industry. That may actually decrease the likelihood that this could be scaled nationwide until the problem on that side of the issue with respect to the lack of electronic health records in all nursing facilities across the nation. So with that, the committee submits, the PRT submits to the entire committee our recommendation that this that it meets all 10 criteria for your consideration, and we're happy to answer questions.
Thank you, Grace. Any other comments from the other PRT members before we?
Just one thing that we did probe with the submitter, kind of pluses or minuses of why this couldn't be done with just enhancements in the fee-for-service schedule or thinking about a more simple way to structure this. So we actually kind of went pretty deep into that, and that's in the transcription, but got a pretty good understanding of why there's a compelling argument, kind of speaking to number one for scope, for why there's a very compelling need for an actual APM in this setting.
I'll also just add, there are two, I think, issues with this one that we're seeing with a number of applications. One is that to some extent there is a shared savings option here because of some feeling that there needs to be a shared savings option, and not because it has been tailored precisely to this particular service. So as Grace mentioned, there were assertions that there would be more flexibility under the shared savings model. The notion was that if you were accountable, then you wouldn't have to be so restricted in terms of exactly what services you deliver, but that wasn't clearly articulated. The other thing that I think is parallel here that we've seen now in a couple of cases is that it's a proposal brought to us by a fairly large organization that did it in a large setting. So Avera did this across a large number of sites and found that it was workable. And it's really useful to know that it works. It's not just a theoretical concept, but in fact this kind of an approach works. What we don't know is how extensible it is to smaller settings. And we saw that in the home hospitalization proposals, et cetera, is that there is a hope that it could be done that way. So, but I think in this particular case, my opinion is there's no way to know that until you try it. And you can't try it if there's not a payment to be able to support it. So I think that to some extent what we saw was something that was designed based on the way that the people who are doing it do it, with the hope that it could be done by others the same way, but without necessarily experience to back that up. And I think the only way to find that would be through testing.
Bruce?
Yeah, thanks for that good presentation. So these are all obviously all Medicare patients, but the Medicare Sniff benefit is very limited. I wondered, is there any sort of relationship between the model and Medicare Sniff benefit? Are any of the patients eligible for the Sniff benefit when they enter the model, or is it really just a population of patients who reside in a nursing facility and happen to be also eligible for Medicare?
I believe it's the latter. I mean, if the concept was how physicians would be paid, who there are patients that are there that are on traditional Medicare, and that this is an additional service that could be provided as a payment model. The piece of that as it relates to patients and their benefits was the concept that they would not have to pay for this in any sort of cost-sharing way that might be part of their traditional Medicare now.
So I think just to be clear, that the patients are Medicare patients, as Grace said, and they could at any given point in time either be eligible for the Medicare Sniff benefit or not, depending on whether they had been hospitalized recently. They might have come in initially into the nursing home that way and then essentially became a long-term nursing facility patient. They might have been a nursing facility patient who then was hospitalized and qualified for Sniff benefits. So at any point in time, there will be a mix.
Tim.
Thanks for the PRT and thanks to the submitters for working on this very important space. I completely agree with you, Grace. A lot of my patients are in nursing homes. I had a series of questions, and some of them are high level and some of them are sort of detailed technical, so I'll just try to get through them quickly. The first questions relate to the performance measures. And I found the denominators for the performance measures odd. I wasn't prepared. They were facility level, patients in the facility level. And that was a, I'm not sure how I would understand comparisons if the denominator is at the facility level rather than the payment entity, the entity that is like all of your patients that you have care for rather than at the facility level because of all kinds of interesting risk adjustment issues and so forth. So just the denominator had me a little scratching my head. I've never seen that before and didn't know how you were going to do benchmarking and so forth. And I just wondered if that came up in your PRT.
We did talk about it, and we actually then kind of opened Pandora's box of how do we even, with our like technical, like our subcontractors, try to even get, and you'll see some of the conversation and the data that we tried to extract what that would look like on a more national representative population, and it's extremely difficult to do for all the reasons that sniff claims are problematic.
Right.
So we were trying to approximate as best as we could in the kind of literature scan and the data tables, but it was another aspect that was a limitation. So that gets to, I think, Harold's kind of meta point of there were things that are very clear that this is, Avera does just a great job at,
Right.
and that's one of the areas that we would say is probably combined with
scale.
risk adjustment.
Yeah.
The scale issue, yeah.
Well, I'd add, this model is, and they can describe it themselves, obviously, but I think this model is sort of unique in the sense that it's partially a service to the patients, but it's partially a service to the facility.
Right.
And so the advantage of this structure, because you're right, it isn't typical in some ways, but in other ways, I mean, you know, hospitals get measured based on what they do for everybody in the hospital, and the advantage in this.
In that case, the hospital is the unit of payment. In this case, it's
no, I
the
understand
facility
that.
is not the unit
but,
of payment.
Right, but I think, but the issue here is it also avoids the notion that it's based on the status that the patient happens to have at a particular point in time, back to this sniff nursing facility, et cetera issue. So you're absolutely right. I mean, it's different. I think that given the nature of the service, to me, it actually made more sense in some ways because they're trying to sort of help the facility, and the notion that it is a facility-wide service and they can't sort of say we're only doing this for a subset of patients that we happen to pick in a fashion that might be convenient, had some advantages to it.
And within that context, their point that it should be a facility-wide service with the exception of somebody that opts out was a crucial component to why they thought it would work, because they don't need to be, a nurse in the middle of the night just doesn't need to be deciding, is this one that can use this service or not? Right. So that, to our mind, made sense. The other point in this is that because there's not that many measures that are out there, they all happen to be at the facility level, what is there, and so therefore what they're working with are the standards that are out there right now. So that's, again, I think they're starting from what they know, and, you know, and based on that have created payment models around it.
So just, I don't want to belabor this minor technical point, but it does make you wonder how you create thresholds then for performance. If you have 6 different facilities, 3 perform well, 2 don't, like how do you decide whether or not you're doing well or not? I'm sure there are ways you could do it, but it's novel. The second thing...
that was one of the concerns we had, that there's no sort of risk adjustment structure, and you can't tell whether you have a different population in one facility than the other. You're absolutely right.
Yeah. And then the other one is, you know, among the measures, I didn't see, there was only one measure that I was actually looking for, and I didn't find it, which is, I don't think it's, personally, I'm just make a strong statement here, I don't think it's acceptable to have a patient in a nursing home and not have an explicit documented goals of care. And I read through the stuff and I didn't see a goals of care. I think that should be a requirement of any payment policy in that setting, a la our discussions yesterday. And so I just, was a goals of care issue raised?
We didn't raise it as explicitly as you did. We got into it when it came up as part of our discussion around kind of tell us what your branded approach, so to speak, is to care for the geriatric patient and how you are coordinating that care with the patient's needs in mind, as well as the primary caregiver and potentially primary care physicians and specialist network. So the way you stated is a much more clear way, but we kind of got into it through their process, which
I'm sure they do it, so it's probably they
it's
they
good.
Just
I don't
didn't
recall.
include it because they do
I don't
it
recall us calling it out as an
standard of
explicit
care.
need.
Well, I think, again, this is sort of an interesting model in the sense that it's not a nursing home payment model. It's a model for a support to the nursing home. So you'd say, well, so who's responsible for the goals of care? Is it the nursing home? Because this isn't affecting their payment for the nursing home.
Yeah, but they're creating the medical plan. They're doing an intake, like.
Yeah.
And they can't make decisions about what you're doing with the patient in a particular medical context unless there are an explicit goals of care.
But I think we felt in general the quality measures needed some work. We didn't think that in a sense that it was another one of those they need some work, but it's not that it can't be fixed. It's just that the ones that are there right now don't feel to us like they're exactly the right ones.
Okay. So the relationship with the PCP here was a little, I'm again scratching my head over that one. So, what they're doing in the plan of care, the creation of the plan of care, that seems like sort of a comprehensive plan of care, seems like the PCP stuff, and they're providing 24/7 call coverage for acute issues. So I'm not sure what's left over for the PCP. And this is I think this is an important issue. Most patients that I know of in nursing homes, you're either the facilities doctor or you have your PCP, and the nurses call, one way or the other. This is sort of an interesting hybrid where I didn't understand roles and responsibilities.
We explored that in a fair amount of detail and discussed it among ourselves, but part of their model is they're working with what is there. There still needs to be a medical director in a nursing facility. There still needs to be PCPs that are there. They could be hundreds or thousands of miles away, since this is a telehealth process. So it may be more that we want to explore with them what their experience is doing this with PCPs, but we spent a lot of time actually thinking about that. Their responses, which are, I believe you'll see in the dialogue, is that they did not want to be a disruptor of the traditional PCP relationship. So what is not in the model are explicit I guess, requirements or as to how they will actually interact with the PCP. As we mentioned earlier in our comments, that it's about a collaborative relationship. So what you're getting at is how do you go from aspirational to something that involves a local person that's part of a team with a geriatric support that's doing many of these other things. So that might be a good question to ask the
And I'll just add, Tim, that we kept coming back around to thinking about scale beyond or even inside of this kind of model. I would say two things emerged: just the need for potentially simplifying the payment methodology, and then number two, I'd now add in the goals of a care plan into the same kind of consistency or responsibility for coordination and accountability of that coordination, because we even brought up, like, does this have to be a geriatrician, a board, potentially, and it does seem like this particular submitter makes a great case for it should be a geriatrician, knowing that that's not necessarily available in all facilities. But they also made a point to say that, like, within an hour, they coordinate with a document, usually by fax, to the PCP, and that that's consistent and continuous. So I think they have processes in place. We asked about metrics to kind of demonstrate that accountability. I think because they've been doing this within their, like, technology infrastructure, they're able to do it within their facility, but there's not some, NQF measure number 21 for documentation of goal of care and NQF measure 23 for coordination with the PCP. So I would strongly add that in as suggestions if this committee moves forward to improve the model.
Great. Just two more. So the I guess these are related. So it seemed like 2 years was a really long time to get to performance. Like, this is the kind of stuff where if you're on top of it and you're starting to treat UTIs instead of sending them to the ED, which is the most common reason for a transfer from a sniff to a ED, like that should, like once you're providing the care, that should start happening right away. So 1 year would seem to me to be a generous period for getting to performance. And related to that, this issue that you raised really struck me that you did conclude that it met the value over volume and the payment methodology criteria, and yet you also pointed out that you could actually fail on the ED and admissions, since that is where the cost savings is, unless I'm missing something. I don't see how you can say, please explain to me how those two things could be simultaneously true, that you could not include ED and admissions in the performance and guarantee that you're actually, reducing admissions. Like the fact that they were separable seemed to me to be, at least in model 1, or the performance model, not the total cost of care, because it would be covered in the shared savings model. But I didn't understand how those two things could be simultaneously true.
Because it's a fixed fee per patient, irrespective of the type of services provided. We felt that is a type of payment model that will not necessarily entice excessive service. You're talking about the measurement of the actual performance of services that may or may not occur. And that is what we did point out, is that those two things are both true, that they're not paid on a per service basis, which may therefore improve value over volume. But in the simplified model, they're also not held to performance standards for other services provided.
So they're getting paid, but they're not necessarily delivering on the outcome that is the critical outcome.
Well, other than over time, those numbers are adjusted. In year 3, I believe, in the simple one, for poor performance and cost.
But performance not necessarily including ED and admissions, which is the big performance issue that would guarantee cost savings. The other ones are all great, and I don't want to imply that I'm against any of this.
That's fair. I mean, I think we did discuss the fact that you could still do very well and negatively perform, to your point, on those measures, and felt like the best way to say it is that we felt like if they did demonstrate on quality overall, that was not necessarily a problem, and that was another. It was also related to the fact that we thought that having these two options were problematic, and that we would actually strongly consider a modification of blending of some kind, and that would actually take care of some of these issues. So,
Great.
I don't know, Harold, do you remember? I'm trying to.
Yeah, I mean, I got to say this from my perspective is you're absolutely right, but I guess the way I looked at it was the measures are there. If you do badly on a whole bunch of things, you get penalized. It was only in this, and so my attitude was, I don't think that's good, but I think that's sort of fixable by a tweak, not something that you would say kind of the whole thing falls out because of that. And I think we all struggle with this sort of where is the point where it's sort of fundamentally bad, or where is it that the way they made the judgment about it we thought was a little short of where it should be. And at least my personal way I came down was it was short of where it should be, but kind of the elements are in here. They just need a lot of tweaking to
And
be
Tim,
able to make
something
it right.
that was an undercurrent, and Grace mentioned it, but I'll emphasize it, was that we were nervous also that there would potentially be such a pressure to not put people in the hospital when they needed it. So honestly, given the lack of data, the lack of understanding in this space, it felt like to me that we were okay with sliding on the ED admit side because we didn't want to create what we're seeing in current innovation models where it is like, no going to the ED. So in a way, we wanted to almost, I hate to say this, it's almost like let this play out and understand the data better, because to your point, what we have is very limited understanding.
Great, I'm sorry, I know I'm going on, I have one more.
Oh, go ahead, Tim. I had a comment to make specifically about this, but if are you going to move on?
Go ahead.
I guess when you're saying the data is not there, I think that these patients going to the emergency room and these patients getting admitted to the hospital are sort of those two issues are the crux of what's driving quality and cost for these patients. That the issues are not being remedied at the home, and they're showing up in the ED and they're showing up in the hospital. So I guess the way I interpreted Tim's question, which was also on my mind, those are the fundamental reasons, not the only reasons, but fundamental reasons to why you would want to employ a model like this to attack those two challenges for this population. And if I understand the mechanics right, you could still perform economically well with the measures and miss on those two. Is that technically?
I think I just reinforce what Kavita said. I think there is a real question about how to define whether they missed on these measures initially. This is not a well benchmarked population, and given what they're trying to do, and we don't want to, I would not want to penalize a facility that had already been figuring out the right way to do it, again, by saying you didn't reduce or whatever, or had a particularly challenging population given the nature of what was going on in the community. I mean, the other thing to think about with this, at least from my perspective, I've seen this in a number of different rural communities that I've been working with, which Avera does a lot of work with, is there is a severe shortage of any kind of home care options in those communities. And you end up seeing, depending on the community, very, very different populations in the nursing home based on that. Some cases you may see patients who are much higher acuity in the nursing home because they can get lots of stuff in the home, and others that you can't. And I don't think we're anywhere near being able to understand kind of like whether a particular nursing home is doing well on that measure, and whenever we get out of this. So that's more the issue. Again, it's back, I think the point is right. The question is, I'm not sure that I would say, hey, applicant, go and come up with a better model right now, because I'm not sure that they could, when we talk about trying to extend this to the smaller populations in different areas. So that's the only thing, again, from my perspective, is I think the point is right. I don't think we should say somehow it's okay not to be worried about ED visits and hospitalizations, but to say we know exactly how to build that into a payment model, I'm not convinced that we do.
One more point before you get to your next one is, one of the Secretary's criteria, access is not a criteria of the 10 criteria that we're supposed to evaluate against, but I think there is an implicit value that sort of permeates a lot of the things that we think are important to value for care with respect to access in this model, where access to certain types of expertise in the middle of the night or whatever that's usually not there will in and of itself prevent certain types of behaviors and consequences for patients. So to Harold's point, the data to measure that is hard to come by, but one of the things that this absolutely does is provide access to geriatric expertise 24/7 in remote locations that otherwise would not have that. So that in and of itself is a way of thinking about this, even though we don't have the data yet, if you will, in terms of understanding. If we believe that, which I believe that the submitters believe, and which I happen to believe, that geriatric care adds value, having it for a population of primarily geriatric patients who are frail, elderly, and sick 24/7 as an access value ought to be able to demonstrate over time many of the things that we're not able to measure here.
Great, no disagreement from me, certainly on that, particularly around the care model issues and the lack of access. So my last question is sort of dollars and cents. So so I just did some math around the PBPM and the 5,000 patients times a year, and so it looks like the run rate per, and I don't know what the unit is here, is $3.3 million annually to cover those 5,000 patients. And it seemed to me, on one hand, was that a big number or is that a small number? Well, it sort of depends on what the infrastructure is you're covering. If that's a geriatrician, that's a really big number. If that's a geriatrician and a team and IT infrastructure, maybe it isn't. But did you probe the basis for the cost that were covered by that amount?
Yes. If you look at the transcript, you'll see my sort of colloquy with them about sort of what goes into the number and what number works. It is sort of, I guess the rough summary of that was, if you're going to have this whole team of people available, you may need that to be able to do that. The question, though, is if you're going to have that whole team of people, it's probably not enough if you're doing it at a smaller scale. So then the question becomes, okay, is that the right amount of money if you're doing it on a smaller scale and it's only supporting a geriatrician? And is it okay to only have a geriatrician and not to have a whole complement of pharmacists and social workers and everything else available? And that gets back to this, it's just not clear right now what really, we have one model supported by a Hickey Award that says their particular model worked and this is what their model cost in their scale. And so the calculations I ran were sort of to answer the question, if in fact you had those levels of payment at a much smaller scale, would it be enough to sort of support a basic kind of core element of sort of a geriatrician? And the answer to that seemed to be, yeah, it actually ends up being the right amount. What we don't know is that team too small to be able to achieve what they were able to achieve? Don't know yet.
Yeah. There's an interesting and somewhat probably unique fixed cost, variable cost issues going on here.
And it might be good to have the submitters just give us the example that they kind of went through with us, because they did this down to $1. This is probably one of the most informed PBPM amounts I've seen, just because they've got, like, they're dealing with their fixed costs. And we did ask about, for this GCT team, what's the ideal composition? And they were able to speak to that, which once again brings up the issue that could this be scaled beyond what they're doing? Maybe, but we don't know.
So apologies to the chair for taking up so much time, and thanks to the PRT for their excellent answers.
Apology accepted.
What about to the rest of us?
Len.
Picking up on Tim's good line of questioning, I mean, you know, I'm an economist, so I know the data that I've dealt with, and I know deeply the flaws in claims and EHR and survey, but this sniff business, so tell me again why we can't risk adjust? I just assume that data is perfect if I haven't touched it. So tell me why we can't risk adjust. What is it about? We must have ICD-9s. We must have whether or not they were admitted in the last 12 months. We must have whether or not they went to the ED in the last 12 months. We must have something. How can it be impossible
It's not that it can't
adjust?
be risk adjusted, it just hasn't been done for this population. So if you look at
Ever? I mean, there are a lot of people out there in AI doing prediction of low probability events that are doing exactly this.
So if you think about HCC coding or many of this type of claims-based coding, it was not built around a population of people in the SNF. It's not necessarily that you couldn't risk adjust. It's just that there's no standards related to it. And they didn't put risk adjustment in there.
And we agree with you, Len.
In the whole world.
And because it's going beyond the standard Medicare, I mean, there were a number of issues beyond. It's beyond the standard Medicare benefit potentially. We know that those are people that have been, the duals thing wasn't as much of a problem as we thought it might be, but we would agree, and that's why it would be something that would strengthen this to actually
So I'm really trying to get to,
propose
are the
risk
data
adjustment.
available, or is it just not been done?
Well, it's not been done.
Okay.
I mean, I'll give you one quick semi-related analogy. Medicare has launched the entire comprehensive care for joint replacement model with no post-acute care risk adjustment at all. So a patient who comes in for a hip replacement, some of them live alone and are going to need to go to a skilled nursing facility, and some of them don't and are going to be able to go home. And there is absolutely no adjustment in that model for that. Could it be done? Sure, it could be done, but has it been done? It has not, and you know that requires linking information about post-acute care functional status with hospital, and nobody's collecting the functional status sort of during the hospital stay, et cetera, right, as afterwards. Now, that's a somewhat different thing than this, but here's a situation where there are RUG scores for nursing homes that are intended to measure something about the level of resource need in the nursing home to take care of the patient, but nothing that says, so what's their risk of having to be admitted to a hospital, go into an ED, et cetera. Same kind of a thing, right? So we have a system that's based on kind of the facility that they're in. We're not looking at the issue of the risk of them having some other thing afterwards. It can and should be built in, but right now, the nursing home is not accountable for how many ED visits it has, so nobody's figured that out. So that was the point. Again, I think back to this issue of, should it be there? Yes. Is it reasonable to expect the applicant to have developed that before they bring us a model?
No.
Yeah,
Oh,
right.
I concur. Okay, so Tim, that may be one reason why 2 years is not such a bad plan. Okay, second question. On the quality target business, especially the thing about if you satisfy more than 8 or whatever, you know, so you don't have to satisfy ED in hospital. Why not weight those 11 things in a way that makes more sense? Doesn't that seem obvious?
Why don't you ask them?
Okay, fine. And then I was really intrigued at the 2 model, if you will. Here, you pick, and y'all really didn't pick. You just sort of said, well, you might ought to have a hybrid. So what do you really think? Should we have one, or should we remake this?
This is not the first model that we've been presented this with now as a PTAC. And we did not pick because we don't think that that was our role. We looked
as
at
a
both
PRT.
of them. Yeah, we looked at both of the aspects, commented, made analysis of both aspects, what the weaknesses and strengths were. But this, maybe as we're having our broader discussion about this today, we can start deciding as a PTAC how to address this issue, or maybe we can start in our commentary saying it's actually making it more difficult. We put in our report that had it been simpler, it would have possibly been stronger, but that's all we did. We did not pick.
I think the other issue is what came up in the discussion yesterday is I'm not sure there is one model for everybody. And the notion that we could pick one and say it's better when you'd say, gee, the first model really might be the only thing that could work for somebody who's trying to do this with a few small rural facilities. And the other model, again, I'm not saying it's these models, but there might be a different model that had different resources, different accountability for somebody who could do it on a bigger scale with different kind of resources. And right now, we don't know which of the delivery models is better and whether they could, any one delivery model could work in multiple places. So I would be reluctant to have us say we picked one as opposed to saying we need some better information as to which of these models might work in different settings to determine whether or not two are needed or not. And we don't really have enough information right now even to make that judgment, I don't think.
Well, I would agree with you, Harold, which is why I mean, the applicant said they wanted PTAC to pick. I would say I'd rather try them both and let people out there in the field choose which one to test and so forth.
But I think the U-pick was more of this common problem is nobody knows what Medicare will approve, and so they have two different models, and they think that we're Medicare, and so we can pick one, and that ain't true either.
Plus the AAPM, I mean, they didn't try to, just to be clear, they did not invoke that in their proposal, but it's clear to me that there's a lot of this, like, flavor of, oh, if we put in, you know, shared risk, then that'll qualify them for an AAPM. And so we didn't feel like that. That was another reason it was just too hard to say no, away with option number 2.
Bob.
Well, the PRT did a great job of asking all the questions I could possibly think of. I'm going to probe just a couple of them because I wasn't quite satisfied with the answers and I wanted to get some sense of the PRT. I'll mostly be asking them. Tim has raised the one. I just want to pile on a little bit. It is this diffusion of responsibility between the PCP and the entity, the geriatrician entity that's taking risks. So it's related to the shared savings thing. I think they're trying to have it both ways. The question here is, how does the model guard against patients being kept out of the hospital inappropriately? And the answer is, the PCP remains the party ultimately responsible for coordinating care and has no monetary incentive to inappropriately keep patients out of the hospital. So they would be the protection for the patient. I don't know how that happens at 2 in the morning when the patient spikes a fever and is coughing. I don't see how the entity that has the shared savings incentive is different from the primary party, the primary physician who's responsible for the patient. So I'll be pursuing that. I mean, does the PRT have anything more to say on this one?
Well, as I told you earlier, I had copious experience being the primary care physician who's called in the middle of the night. And so as I was reading this proposal and hearing their answers, I was thinking about the actual logistics of what would likely occur. And my thought process was that and we can, as you said, explore this in more detail. There's a lot of calls that happen now, usually at 3 o'clock in the morning, where a patient is found to have some event that the nurse calls a physician on the phone, who's typically a physician who doesn't know the patient because it's statistically in a call group. It's going to be more than one person. So the default is always go to the ED because there is no likelihood that that's going to, anything else is going to be the right answer when you don't know the patient in the middle of the night and you don't have a lot of access to things. If there is now inserted in that process, this is the way I'm thinking about it, a team that actually 24/7 knows the patient through electronic means or otherwise, has access to the care plan, and otherwise is involved at that level, and they are called first, there may well be information that is part of that process that will allow other things to be done besides an emergency default call in the middle of the night. But just like now, if I were on call for a primary care physician and the next day they get the call or they're looking at things and they're basically saying, well, you know, jeepers, this person has this or that, we ought to be doing this or that. The ultimate care is the responsibility of that person, the way our system is set up. I think what this does is actually for the other 4 out of the 5 nights that the person who's on call is actually out there, that this is just a different or better level of service, information, care planning, and all that. Now, that's my thought process about it, just as somebody who's experienced it. I mean, I think back to the days when I used to be on call for the ED and had to be the one that actually went in after I told him to go to the ED. And I was on call for 8 nursing homes at a time. And that particular system is just terrible. And that's still where it is in a lot of the country right now. So had I had this service back then, I would have probably stayed in the nursing home business a whole lot longer.
But it does suggest, let me just respond, there a real need for end-of-life planning coordination between the PCP. It can't simply be, hey, you get a call at 2 in the morning, you're the geriatrician who's staffing the office that night. That all has to have happened and to be continuously updated. I mean, it's a real effort to pull that off. Okay.
I think one of the weaknesses that we saw in the proposal was it wasn't quite clear that there was a clear connection to the patient's preferences. But I think to the question that you asked, to me, the answer that I guess I found convincing was they're there at the invitation of the facility and the medical director, et cetera. And so if they all of a sudden start saying, don't send the patient to the hospital and bad things happen, the invitation will be withdrawn. Yeah. So it might not happen, you know, at the individual patient level for the first couple, but then, you know, it would be stopped.
That's a good point. To me, it's another suggestion that shared savings is not an appropriate approach for this population.
One other issue that this is sort of related to is the point that I made, or that we made in our report, that you can't tell how much of the elements itself is actually crucial for the actual model of care and payment. So there's data out there now that facilities who employ a nurse practitioner or PA during the day as part of the facility have better outcomes than those that don't have them, that simply rely on primary care. It may be the same phenomenon without 24/7 access, in that you've got somebody right there as opposed to some doc in town she's trying to, you know, see her regular patients, or you know, somebody's rounding periodically. They have developed a particular care model that appears to work through telehealth and improves access to places. They have put a payment model around it that we're looking at right now, which is, I think, crucial. But the very components of the various things in terms of what's crucial in all of it together is not clear to me.
Mm-hmm. Okay. The second area is, and you made a little brief remark that you wound up being satisfied about the duals issue. Medicaid and Medicare having completely conflicting incentives and cost shifting. I mean, there's a whole duals office at CMS somewhere up there. There have been demos. 2 of them are fee-for-service demos. Evercare has been around for over 2 decades. It works, and yet it's not widely adopted anywhere, and I'm not exactly sure why, but I suspect it's because there's this fundamental Medicaid incentive to send patients to the hospital, not only because you can hold the bed and not have the costs of the care, but to get the 3-day stay to then have the patient come back as a SNF patient. In the HICIA, I guess this is the way to ask the question. In the HICIA ward, is this not a problem? I mean, in their results, they're able to sort of, their response to the question when you asked them was, well, we're not making it worse. And then they had some mitigating factors. But the question is, can this model work unless you actually do the financial alignment is the question I have, and is there any instructions from their HICIR experience that would help us know that this is worth doing even if we don't get those financial alignments, or that this should happen in certain states that are making a commitment to work through those issues? That's my question.
And I'd just like to pile on, because one of the things that I noted in the Q&A was that the resistance seems to be from the local hospitals, which isn't terribly surprising. But so how, the scalability, if there is not a receptive community, is one of my questions.
Yeah, no, so I was going to ask, you know, if the demo happens and maybe nursing homes don't want to participate. I mean, you're emphasizing the hospital, but how do we know that there's actually going to be receptivity to bring this team in?
Well, the receptivity, they've got experience with themselves. So we did ask that, you know, what types of, and one of their answers was, you know, at the facility level, when somebody, where they started this, initially the services were not used. Before it was over with, they were just absolutely, completely part of their process and all that at the per unit nursing facility level. What you're saying is, well, what about these others that are out there that didn't want it, never were involved? Can you look at the two? Were the incentives different, you know, in terms of all the issues around the dual eligibles and all of that? And that'll be worth exploring with them. But I do believe their model has to be based upon receptivity. I suspect, from my personal experience, that many communities are not served by the current primary care dependent model or medical director dependent model, and that for many this would be a solution to many problems that they don't have. But it would be something well worth exploring in more detail with them.
Okay, that's all.
Thanks, Bob, and thanks to the committee for detailed exploration. And I think that, frankly, we set the table for the submitters to come on up to the table, because there were a lot of questions that I think are best delivered to them.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.